So we'll go ahead and start. Our webinar today is on management or approach to management of a patient in status epilepticus. Our presenter today is Dr. Yvonne Nyakeri. She's a consultant pediatrician and pediatric neurologist. She'll be taking us through this topic. If you have any questions, please share them, and she'll be able to answer them at the end of the lecture. My name is Dr. Kaileme, and I'll be your moderator for today. So I think, Dr. Nyakeri, you can go ahead and start.
Good afternoon. My name is Dr. Yvonne Nyakeri, and I will be taking you through this brief topic on approach to status epilepticus. Sorry, I'm just going to scroll to the next page. Sure. How to scroll? Okay. So the outline of my presentation, will start with some case presentations. We'll go through a few definitions and background and basically the approach to management of status epilepticus. So the first case, we have a mother who runs to the emergency department holding her 3-year-old son in her arms. He has mostly jerking of the right side and his eyes are deviated to the right. He's foaming at the mouth and it has been going on for 15 minutes. His lips are slightly blue. What would you do first? The options are there, just for the interest of participation. Maybe somebody can write on the chat what you think the first thing to do for this child. Right, the first thing will be then putting him on oxygen as the first aid thing to do. Thank you, Winnie, for that answer. We have a second case whereby we have a 4-year-old female who has known epilepsy due to a genetic condition. She presents to the emergency department. Her current medications are levetiracetam only as a monotherapy. So you observe that she's actively convulsing, which is bilateral tonic-clonic seizure, and her eyes are wide open, they're deviated upwards and she's frothing in the mouth. The duration is unclear as she came to you when she was still convulsing. However, we suspect that it's been going on for more than 10 minutes. She has already received her first dose of rescue, parental diazepam. So what will you do next? So for this girl, the first thing they did was ABCs, that is the first aid for seizures. And then as somebody is still managing that, you start to prepare the second dose of benzodiazepines and also to plan to administer second anti-seizure medication. So looking at the cases that we've presented, we will go through some of the things that we commonly use to manage status epilepticus, and we will be able to look back at the cases and reflect on them. So in essence, what is the definition of status epilepticus? This is a seizure that is lasting more than 5 minutes, or you have a cluster of 2 or more seizures without return to baseline in between the seizures. And this is something that has been adapted as far back as 2012. Previously, we used to use a definition of seizure lasting longer than 30 minutes. However, we know that once a seizure goes longer than 5 minutes, the probability of it stopping spontaneously is quite low. A patient will need medications to stop the seizure. The International League Against Epilepsy describes status epilepticus as a condition that results either from the failure of the mechanisms responsible for seizure termination, and therefore the seizure continues for longer than usual, or from the initiation of mechanisms which lead to abnormally prolonged seizures. And basically, it's a condition that has long-term consequences. What happens is you have neuronal death, neuronal injury, and alterations of neuronal networks. And this definitely depends on the type and the duration of seizures. Looking at this definition of longer than 5 minutes, this is typical for generalized or tonic-clonic status epilepticus. When you have a patient who presents in focal status epilepticus, you will consider status epilepticus when it's a duration of more than 10 minutes. And for the patient who is an who has absent seizures, if they present in status epilepticus, the patient will be in seizures for more than 30 minutes. Status epilepticus is the most common pediatric neurological emergency. And it's important for all of us to focus on this because rapid and effective treatment decreases the risk of cardiac and respiratory complications. It reduces ICU admissions and also reduces death. Looking at the incidence, this is a study that was done in Kenya in early 2000s, whereby they looked at the incidence of status epilepticus for children in Kilifi, and they found it to be about 35 per 100,000 children per year. And some of the factors that affect the outcome for the patient who has had status epilepticus, you have the non-modifiable factors like the patient's age. The younger the child, the poorer the outcome, and also the etiology of status epilepticus, which we're going to see in the next slide. Other potentially modifiable factors that affect the outcome are the duration of status epilepticus. Those ones which take longer duration to get under control have a higher likelihood of having cognitive and neurodevelopmental impairment. This brings us to the morbidity and the mortality consequences as a result of the status epilepticus. The morbidity has been estimated to be about 10 to 20% in different studies that have been done. And basically, once you have neuronal death and neuronal injury, as a consequence, you may have permanent neurological damage. For example, cognitive impairment, neurodevelopmental impairment, and also behavioral challenges. Other consequences include epilepsy and recurrent status epilepticus. The mortality rate varies in different settings, but it has been approximated to be between 2.7 to 8% in international studies. In the study that I alluded to earlier, done in Kilifi, the mortality rate was at 15%. And the most predictive outcome of mortality is the etiology of seizures. Looking at the causes of status epilepticus, this can be divided into different categories. We can start with the acute symptomatic, whereby looking at acute infection, and this is one of the common causes. You can have systemic infections, and you can have also focal or CNS infections like meningitis. So like the systemic infections leading to febrile seizures. Other causes include CNS trauma, metabolic derangements like hypoglycemia, hyponatremia, also hypoxemia. You can have this during drug withdrawals. This is for possibly the older children. And also for the children with epilepsy, once you're doing medication adjustments, including drug withdrawal, they could land into status epilepticus. Others include toxins and metabolic precipitants. The second classification would be remote symptomatic, and this includes the children who have static conditions or remote injury, brain injury, for example, hypoxic ischemic encephalopathy from brain injury. Another classification is idiopathic. So you have investigated the child and you've not been able to find the cause of why the child went into status epilepticus. The reasons for us to know about the etiologies will be important because we know that recurrent status epilepticus commonly occurs in children with neurological abnormalities, and you know how to manage them in future. And this includes providing them with a plan, a written action plan to present to the hospitals in case they present in status epilepticus. Idiopathic and remote symptomatic group, they have the highest recurrence risk, and this was estimated to be about 28% in one of the studies. The children who present in febrile status epilepticus have a low recurrence risk of about 3%. So looking into the management, what are the goals of management for our patients with status epilepticus? Number one, we want to treat them rapidly within 5 minutes of seizure onset, and you want to continually do sequentially until the clinical and the electrographic seizures are terminated. And ideally, this should be within 60 minutes of onset of the seizure. Number two, the etiology of the status epilepticus will be diagnosed and treated as soon as possible. And this treatment and the diagnostic evaluation should actually be done concurrently when you have the patient with you. So there are very many clinical guidelines that are available. However, this provides little information on efficacy and safety to guide the choice of second-line therapy. As a result, the treatment choices are usually driven by habit of institutions, training of those in the institution, and also by tradition, as well as by evidence. So we'll start with the immediate management at 0 to 5 minutes. And on the right side is a pictorial of the basic pediatric protocols, which provides a very adequate summary of what to do when we're managing seizures. Is that you want to do adequate first aid. ABCs is very paramount, and this involves airway protection, and this can be as simple as positioning with a head tilt or with a jaw thrust maneuver. And if needed, immediate intubation can be considered at this point in time. So you need to administer oxygen for the patient and start cardiopulmonary monitoring as soon as possible. Establishing IV access, and when you establish the IVs, you collect blood samples for immediate lab testing, including glucose. So within the first 5 minutes, you're going to be preparing the medication that you're going to give as first-line therapies. And the medications, the first-line therapy is benzodiazepines. What is available to you in your setting is what will be important to administer to the patient at that time. If you have an IV, common medication used is lorazepam, and diazepam can also be administered based on the protocol in your hospital. If you have no IV, midazolam can be administered using the intramuscular route. It can also be administered intranasally and also through the buccal route. Diazepam is a good medication to administer rectally, and I believe that this is a very common medication that we use in many of our institutions. So this will be provided if the child has been seizing for more than 5 minutes and you continue reassessing. After administering the first dose of the benzodiazepine, if the patient continues to seize, somebody is already preparing the second dose of the benzodiazepine to administer it rapidly in case the seizure does not abate. It is important to know that 2/3, 2 out of 3 children will, the seizure will abort after giving the initial benzodiazepine. 1 out of 3 of the children may continue to have seizures thereafter. So if the seizure persists beyond 5 minutes, you'll need to prepare and administer the second dose of benzodiazepine, as we've discussed, and continue evaluating your ABCs and correcting any potentially treatable condition that you are able to identify. Once you consider and need to use the second dose of benzodiazepine, you'll need to start preparing to administer a second anti-seizure medication. This can be, there are very many options to use as a second anti-seizure medication, and the option to use is dependent on a number of factors. It depends on what the patient is currently taking. So for an epileptic who is currently using phenobarbital as a maintenance dose, you will want to use a different anti-seizure medication like phenytoin or levetiracetam to administer a bit to stop the current seizure. We treat status epilepticus in neonates in a different way, not providing benzodiazepines as the first line medication. We do start with phenobarbital as the first line anti-seizure medication. You continue reassessing the patient, and as I've mentioned above, you consider potentially treatable conditions like hypoglycemia, hyponatremia, hypocalcemia, hypoxia, CNS bleeding or CNS infection, and hypothermia, and you institute the management as soon as possible. If the seizure continues after administering the second anti-seizure medication, you have leeway to give additional 10 to 20 per kilogram of the second anti-seizure medication. If the seizure continues after 30 minutes, you will classify those status epilepticus as refractory status epilepticus, and you'll consider giving a third anti-seizure medication. And what is the choice of the third anti-seizure medication? This will be the medication that you did not use as the second anti-seizure medication, and what is readily available to you. So basically, if the seizure persists after the third anti-seizure medication, the goal of therapy ceases to be about stopping the current seizure, but to reduce the metabolic stress on the injured and at-risk neuronal cells. So it will be very critical to maintain cerebral perfusion pressure. You want to prevent hypothermia and deliver adequate oxygen and nutrition to the cells. And how do we do this? This is by securing the airway with intubation and providing mechanical ventilation. You have to obtain a central IV access and consider arterial line for hemodynamic monitoring. And you want to support your hemodynamics, meaning to support your blood pressures. Ideally, this should be in the pediatric ICU setting, in which case the pediatric ICU team needs to be involved. At this point as well, it will be important to start continuous EEG monitoring, and therefore involving the neurophysiology department so as to institute continuous EEG monitoring. So we talked about refractory status epilepticus, and we know that amongst all the cases with status epilepticus, maybe 1 out of 3 persist even after treatment with the patients. Refractory status epilepticus is that which is unresponsive to standard treatment regimens, meaning the initial benzodiazepine and 1 anti-seizure medication. So how do you manage refractory status epilepticus? You've already given your benzodiazepines, you've given your second line anti-seizure medication, you've given your third line anti-seizure medication. At this point, you should be in the ICU and consideration to start Midazolam IV bolus and continuous infusion. Other options to use is pentobarbital, which is also given as an IV bolus, loading dose, and continuous infusion. Other considerations or alternative for medications for refractory status epilepticus include topiramate, which is currently commonly available as an oral preparation. So you give it as a loading dose as well and continue maintenance therapy. Others have trialed ketogenic diet during status epilepticus. IV lacosamide is a very good option to consider, very good for focal status epilepticus. Pulse steroids, especially if you're thinking about autoimmune encephalitis causing the status epilepticus, and other drugs like acetazolamide and propofol. So once you have achieved seizure control, and by this time the patient is in ICU, the goal is to maintain the patient at least 24 to 48 hours seizure-free or in burst suppression. And this, you will notice, you will observe it through continuous EEG to weaning the continuous infusions. And before you start weaning the infusions, you need to have identified what anti-seizure medications you will use for maintenance therapy so that the patient does not go back into status epilepticus. So this is a pictorial showing a common study, a very good study that was published in Neurology, looking at what second or third line anti-seizure loading medication would be considered by whichever institution. And basically a meta-analysis that was done looking at the 5 common anti-seizure medications that are used around the world. Phenobarbital was still the most effective with about 80% probability of seizure. As much as it's an old medication, it's still a very effective medication. Other countries, as opposed to phenobarbital, and there was a study that was done to look at the efficacy between phenytoin and levetiracetam, and 2 separate randomized control trials showed that they were equivalent in efficacy. So in practice, what would you do in our setting? Number 1, knowing what you know, especially about the medications, including phenobarbital, what is available will be the most appropriate. You need to think about what the child is already taking and consider an alternative if possible. 20 milligrams per kilo is an appropriate dose for all the medications that have been listed there. And that is a very easy number to remember, especially in a very high-powered situation in epilepticus. I would be able to take questions now.
Thank you, Dr. Nyakeri, for that very informative and interesting lecture on management of status epilepticus. The floor is open for any questions. You can just type them out on the chat and Dr. Nyakeri will be able to answer them.
Okay, I will be able to summarize as the questions come, and then we'll be able to answer them at the end. So in essence, the management of status epilepticus is effective treatment to reduce morbidity and mortality in our children. And it's important for us to consider multidisciplinary team involvement for a patient who comes with status epilepticus. And it's important to know that time is brain. So we need to act promptly and providing effective therapies. Thank you.
Maybe I can start with the first question. For patients who you're managing for status epilepticus, after you've given the loading dose, let's say you decide to start on the second line after the 2 diazepams, and you decide to start with phenobarbital, does that mean that you have to give what you call the half loading or a repeat of the loading at 20 minutes before you go to the third line. In this case, maybe in our setup where we have phenytoin, would your option be to repeat the loading dose and then give the phenytoin, or just go to giving the loading dose of phenytoin?
Okay, thank you for that question. So in our setting, and every setting anyway, so once you've given 2 doses of a benzodiazepine, we know that it is very sedating. So some people or some institutions actually would prefer to start with phenytoin, which is not as sedating. And especially if you do not have access to an ICU, ready ICU in your setting, you may not want to provide the child with 2 doses of midazolam, 20 per kilo of phenobarbital, and then maybe add another 20 per kilo of phenobarbital. So those are the considerations that you will want to have at that point. If you do go with phenobarbital as the first dose, evaluate the child and see what is your risk of respiratory depression. And you may consider actually going to a second, to using an alternative dosing of phenytoin. So I think it's something that you consider at that time based on the resources that you have. If you do have an ICU, you provide the 20 milligrams per kilo of phenobarbital, and you can give either 10 or 20. And we are assuming that this is a child who is not on phenobarbital maintenance dosing, because then that will be excessive provisions for phenobarbital.
Thank you for that. I'll go to the next question. This is from Fatma. Her question is, should I consider doing an LP in every convulsing child?
Right. Lumbar puncture is something that the reason why we're doing lumbar puncture is to investigate for CNS infection. And for the child who comes with a fast convulsion, typically in the setting of a febrile illness, that is one of the things that you may want to consider. And the younger the child, the higher likelihood of them not having the typical signs of meningitis. That is a stiff neck or headache and vomiting. They may not have those presentation. And definitely, prior to considering doing a lumbar puncture, you want to make sure that there are no focal neurological signs or signs to suggesting raised intracranial pressure with risk of having herniation should you have something like a space-occupying lesion in the brain. So it's something that you will consider with every individual case, and more so for the first presentation of seizures in febrile illness. If somebody comes without febrile, if somebody presents with an afebrile seizure, then you may consider other considerations other than a CNS infection.
Thank you for that answer. Our second question is from Rhoda Masaku. She's asking about ketogenic diet and what your experience is with ketogenic diet in both status epilepticus and epilepsy.
Right. So ketogenic diet in status epilepticus is one of the, can I say, the last options that you're trying to use to get the child out of status epilepticus. This is a child who will be in the ICU. You've already induced coma and you've already put the child in birth suppression, but the child's, you've already induced coma, but the child still has an active brain. So ketogenic diet will be one of the last considerations to try for that. I have had experience with this in a child who was very sick and unfortunately did not make it. And it involves basically a lot of preparation with the dietitians, and it's not something that is like will be done on the first or the second day of therapy. However, when you come to ketogenic diet in epilepsy, it is a very, it's a commonly used therapeutic option in childhood epilepsy, all the way from infancy. And it has shown significant success, more so in children with infantile spasms as a third line option. So it does help in certain situations.
The next question is about refractory neonatal seizures in neonates with HIE. The participant is asking if you can consider giving calcium and magnesium.
So in neonatal seizures in HIE, so that is a whole different topic in itself. HIE, you do have metabolic derangement as a consequence of the basically the pathophysiology of what has happened with that child. So if the calcium and the magnesium or whatever electrolytes are deranged, it will be important to correct that. Another important thing to think about is pyridoxine. Pyridoxine supplementation in neonatal seizures, not just in HIE, but basically just neonatal, refractory neonatal seizures.
The next question is from Victor. He's asking if you find a patient who has been underdosed, has been given phenobarbital, but it's underdosed, how do you go about it?
So with underdose, okay. So for a patient who's on phenobarbital and presents to you, I believe that what will be safe in a setting like ours, where we may not do phenobarbital level, is to use an alternative agent like phenytoin to manage the status epilepticus. Do your phenobarbital levels and then adjust the dosing to an appropriate dose so that when they go home, that is probably the primary anti-seizure medication that they will be on at an appropriate dose. So underdose of medication is one of the common reasons why somebody would have recurrent seizures. And so this is a very good consideration. You may, just because you do not know the levels of the baseline levels of the patient, what may be safe is to give an alternative medication and then you increase the dose of phenobarbital for discharge.
Next question is about midazolam, whether it can be used in the wards for refractory seizures after giving the initial anticonvulsants. So you're in the wards and the patient still has refractory seizures. Can you give midazolam boluses? And if yes, what would be the dose and how would it be administered?
Benzodiazepines are best used as an initial anti-seizure medication to stop the current seizure. So why we use midazolam is or benzodiazepines is because we can administer it rapidly meaning for the IVs with you administer it at least within a minute, and it acts very fast, and it acts also for a very short time. That is why we need the other anti-seizure medications, which unfortunately, as infusions, you may need to give it over 20 minutes, and it lasts for a longer time. So in this case, if somebody is having refractory seizures in the ward, after the initial anticonvulsants, I believe we should be looking at other options of long-term anti-seizure medications. So if you're not achieving that with the current medications that you're on, we provide the midazolam as a bolus and an infusion, but only in the ICU setting, because this is a patient who needs to be intubated to protect the airway. If you provide it without the support of an ICU setting, this is a patient who will have respiratory depression and sudden collapse in the ward. Bolus is given as 0.1 milligrams per kilo as a bolus, and continue with infusion. Continue with an infusion at about, I believe, 120 micrograms per kilo per hour. And just to continue on that, if a person has not refractory seizures, but if the person has onset of seizures in the ward, that is not considered status epilepticus as of yet, you can still provide rescue midazolam, and this can be given either IV, it can be given IM, or it can be given through the buccal route that is on the cheek, in the cheek, and the dosing is typically 0.2 milligrams per kilo. But this is to stop a typical seizure that probably just goes longer than the duration of the child's regular seizures. Commonly, we say at about 5 minutes.
The next question is from David. He's asking, in a patient who presents with status secondary to cerebral edema from head injury, would you use the same approach for the antiepileptic drugs?
When a patient presents with status, and I believe during your investigations, that is when you cerebral edema due to head trauma, yes, you would use the same approach. This is the standard of care for patients with status epilepticus. So yes, same approach.
Okay. So these ones I'll put there, sort of 3 related questions. So one is about whether carbamazepine can be used as a second-line antiepileptic drug when you're managing status epilepticus. The next question is, what discharge drugs would you give the patient following successful management of the status in the wards? What would you discharge them on? And the third one is about a patient who has been on oral phenytoin for for management of his epilepsy for many years and has had no convulsions. When would you decide to stop the medication?
Okay, sorry, Kenya, we'll probably take it step by step.
Okay, let me start with the first one. So about carbamazepine, would you use it as a second-line anti-epileptic drug in management of status epilepticus?
Okay, so the reason why we're using the drugs that we are talking about is because they do have IV preparations, and this is an emergency situation. Unfortunately, carbamazepine has no IV preparation, and typically, if you would use phenytoin as medication during status epilepticus, you do have the option of continuing on carbamazepine once the patient is stabilized. Just to put it there that there is, somebody had talked about oral phenytoin. Unfortunately, oral phenytoin, just because of the preparation, you are, it's sort of like the active ingredient and the, what do you call it, there's sort of a separation between the active ingredient and the liquid that the active ingredient is sort of like dissolved in, and families really have to shake the bottle and mix the two prior to administering. And this is a problem that has been identified, whereby we don't know how much phenytoin somebody is receiving orally from the suspensions. So it's something that you want to probably discourage discharging on phenytoin oral and look for an alternative, and carbamazepine is a good alternative.
Okay, so the next question, I think there have been two questions asking when to stop anti-seizure medication once the patient has been managed in the ward and discharged home. When would you consider, or what criteria do you use to stop the antiepileptic drugs?
Okay, so this will be on case-by-case consideration, and it depends a lot on the cause of the seizures, on the cause of the status epilepticus and the cause for seizures. If it is something like an acute symptomatic etiology, you know that once you correct the cause, once you treat the infection, once you treat the electrolyte imbalances, the child should be fine. So this is a child who may actually go home without anti-seizure medication. If it's a child who you know probably has a higher risk of continuing to have seizures thereafter, then you will continue for a longer duration of time. If it's a patient who has a tumor or something that may not be adequately, that cannot be corrected or reversed, or somebody who has hypoxic ischemic encephalopathy, you know that this is a patient who will need to be on long-term anti-seizure medication. So I believe that this will be on a case-by-case consideration. But if it is acute symptomatic causes, actually the anti-seizure medications in the ward prior to discharge, or you may give them benefit of using the anti-seizure medications for even 2 weeks or a month after discharge, and during the review, you can wean it off gradually.
So this is the question on febrile convulsions. One was about it being, how would you diagnose a patient with febrile convulsions, seeing that it is a diagnosis of exclusion? When would you conclude that this is febrile convulsion? And one was asking about management of the fevers in febrile convulsion, whether tepid sponging is still used, and what medication would you recommend for fever control?
Okay. Okay, so yes, so making a diagnosis of febrile seizures, yes, it is a diagnosis of exclusion. So when a patient presents to you at the appropriate age for febrile convulsions, meaning the patient is between 6 months and 5 years, presents with an illness or fever, you, especially for the first presentation, you want to adequately investigate this child to know what is the source of the infection. So it may be a respiratory infection or a gastroenteritis, or something as common as a urinary tract infection. So you want to do relevant investigations for that, not forgetting your blood cultures. So the other thing that you do not want to miss is meningitis. And this is where the question of the lumbar puncture, we believe for the first presentation of febrile seizures, you need to have a lumbar puncture to be able to make it appropriately. So if all your investigations come back and they're negative, then you may conclude that the patient probably has a febrile seizure. How do you manage the fever in febrile seizures? There are multiples of antipyretics. There is ibuprofen, that is what we call brufen, and there is diclofenac, example like cataflam. So you can either use 1 or 2 antipyretics at an appropriate dose and appropriate frequency. If you're having concerns with fevers, you may actually use, for example, paracetamol and brufen or cataflam alternating every 4 hours. We do not recommend tepid sponging anymore. And this is because if we look at the mechanism of why somebody feels hot during a seizure, is because your blood vessels are dilated and they sort of come up to the surface to release the heat. If you are going to do tepid sponging, you are sort of just reducing the surface heat, and then the patient becomes cool. The blood vessels sort of back, what do you call it? Sort of like they don't come up to the surface, so they go back in. But then you've not dealt with the fever. So the core temperature rises, and the patient still has fever, despite you, as the parent or as the caregiver, being reassured that the surface temperature is low. So you have actually not dealt with the fever. So that is not, it's not encouraged anymore. And we need to advise our parents accordingly.
I'm not sure if you've answered this. Again, there are about 4 questions on what is the preferred drug for discharge for status. So some people say
Right.
they've seen some consultants using Rivotril, there's Valproate. So how do you decide which drug the patient will go home with?
Sorry, to discharge the patient in which context?
So a patient who was
Kenya?
admitted had status, in the context of a patient who had status epilepticus, and you want to discharge them home on antiepileptic drugs.
Right.
Yes.
So for the patient who has had status epilepticus, and you've probably given a few medications and that helps to control the seizures. Say, for example, you'd given 2 types of anti-seizure medication, and you've been investigated and you've been able to identify the cause of the seizures. You want to see the medication that you've used, was one of them more effective than the other? Then you may want to choose the medication that we thought was more effective as a discharge medication. Number 2, once you've identified the cause of the seizures, we do know that some medications are better suited sort of for focal seizures, and then there are others which are best suited for as a broad spectrum anti-seizure medication. So if somebody had focal status epilepticus and you've identified that there was a focal, the reason was something that is focal, probably the patient was on phenytoin and phenobarbital or whatever it is that you used. You know, for focal seizures and focal etiologies, carbamazepine will be a good option for them. And worked well during management, then you want to discharge the patient on carbamazepine. Phenobarbital is one of the medications that maybe we want to use less of it as a long-term medication, just because of its cognitive implications for our children. So one of the things that we may want to discourage, and probably it's something that we will change over time, is to not discharge patients on long-term phenobarb medication. So you have many other options that you may probably have trialed during management, and that is what you'll probably look through with the clinical team that was supporting you, and use that as a discharge medication. So I don't believe there's a considerations.
Thank you for that. I can see some hands that have been raised. I don't know, Juliana, if you had a question. Juliana Otieno. Maybe you can write it in the chat. It would be easier to answer. There's a question about side effects of antiepileptic drugs. One is a patient who's on phenobarbital, non-CP autistic child with aggressive behavior. Would you change the medication, even though the phenobarbital is controlling the convulsions well? And the second one is about whether it causes infertility in women.
Okay. So patient with autism. So for patients who have significant like comorbidities, and the patient is on phenobarbital, it may be difficult for you, so to say, active and is not themselves. Another thing to consider is how long has the child been seizure free. If it has been a considerable amount of time, that may probably be a good time to wean off phenobarbital. And another consideration would be, if you just want to change the medication to a different alternative medication, you need to put everything in perspective. If the patient has been having focal seizures, then maybe you want to transition to something like carbamazepine. You may want to do it gradually, and so that you don't rock the boat in terms of seizure control. So I believe maybe the right answer would be, are we changing the phenobarbital just because we are mentally clouded, as opposed to, in this case, the patient asked about, sorry, the person who asked the question talked about aggressive behavior. In a child who has autism and cerebral palsy and is possibly non-verbal, you want to investigate what is the cause of the aggressive behavior. Common reasons are medical conditions. Is the patient constipated? Does the patient have a urine tract infection? Does the patient have any infection at all? Dental caries and dental caries is one of the causes of irritability and aggressive behavior. So maybe just investigate for why the patient is having aggressive behavior, and maybe not attribute it to the anti-seizure medication. Yeah.
Thank you for that. I think we will go to the last question. This is still in relation to management of a child with epilepsy, not necessarily status, who is on phenobarbital at 30 milligrams nocte and Tegretol, a 2-year-old, 200 milligrams OD. They're asking, if the child still has convulsions, would you stop the Tegretol and maximize on the dose of the phenobarb, or what would your approach be?
So this is a very interesting question, and it's something that we commonly encounter. And in essence, as I've mentioned, maybe we want to get off from using phenobarbital as a long-term anti-seizure medication. Not to say that it does not work, it works well. We probably want to reevaluate the child and see what is his predominant seizure type, and do we feel that the reason why the child is actually in this neurodevelopmental difficulty or disability is due to something that is of focal nature or multifocal nature, like HIE or other presentations. then you want to see that you want to optimize one of the anti-seizure medications. And it has to be a discussion with the family on number one, what do you think has been most effective between the two? Number two, we need to optimize one medication and see if the patient actually gets worse in terms of worsening seizures. They need to probably get back to you and see what else to do, or maybe just to change to a different alternative medication. There is no direct answer to that, unless you have probably I can tell the person to get in touch with a neurologist or somebody to be able to have further discussions regarding that specific case, and can be guided on how to proceed with that.
So Juliana, you had a question. If you're still online, you can ask, or I'll move to the next person.
Those people have not sent the link or you, isn't it? So maybe we are not meeting.
Okay, let's go to Rael Sirma. Rael, are you still online? Okay, Waki. Okay.
I check me. Okay, I'm not so much some topic.
Okay, I think we are done with the questions for today. If you have any other questions, they can be directed to Dr. Yvonne Nyakeri, and you'll be able to get her details from the research website. So thank you again, Dr. Nyakeri, for a very informative lecture. And thank you for answering the questions very well. And we've learned quite a lot. Maybe we'll have you again just to answer the remaining questions that have been asked. And thank you all for attending the meeting. I think I'll hand over to the KNH research team for any announcements. Okay, I don't think there are any more announcements, so I'll just call this meeting to a close. And thank you again very much to our presenter, Dr. Yvonne Nyakeri, and to all the participants, and for all the questions and the discussion. Have a good afternoon.